Valley-wise Grand Rounds. Same reminder as each month, Megan will put the CME code in the chat midway through. And please remember that the CME is through Creighton. So if you are texting, you need to type the word attend and then the CME code. Also, please make sure to remember to keep yourself on mute. With that, we're very glad to welcome Dr. Khurana back with us today to discuss pediatric school-age behavioral concerns and what we can do for our patients. Dr. Khurana completed her medical school at the University of Arizona, then stayed here in Phoenix for her pediatric residency at Phoenix Children's Maricopa Medical Center. Then, after seeing the need, she obtained her training for early access to autism care and autism diagnostic training, which allows her to provide the autism diagnoses for DDD. She's the founder of Pediatric Developmental Connections, where she can work with families on autism or dyslexia diagnoses, along with helping families connect with resources. She serves as the co-owner of Healing Hearts Pediatrics, where she's able to focus her pediatric practice on developmental pediatrics. Dr. Khurana is also highly involved in outreach. She has her own YouTube channel educating families on autism, early childhood development, and dyslexia. With that, I will hand the floor over to Dr. Khurana.
Hi, can you hear me okay, guys?
Yes.
Perfect. For those of you that I've not met before, I'm Nilam Khurana. And I'm just gonna figure out how to share my screen here. It's nice to see some familiar names. You should show your faces so I can see you since I never see you. Here we go, share. Okay, so I am going to start talking about behavioral problems in the school-aged child. Why, I don't know. This is not starting. Slideshow. There we go. Okay, perfect. Moving things around here, sorry, so I can see you guys. Okay, so I hate talking to myself when I don't have any responses. It's just a weird world that we live in. So just if I seem a little off, it's because I'm waiting for the pause, or the response, which is not there. But today I'm going to talk about the behavioral problems in the school-aged child. I'm hoping, because it wasn't that long ago, most of you guys saw the one that I had talked about on the younger kids. Because again, there's some areas that I'll touch on very briefly that aren't necessarily my area of expertise, but things that obviously need to be in your differential diagnosis. So there we go. Oh, so she already introduced me, so it's got everything over there. So you don't really need to see all of that stuff. But I am a PCH MMC grad, which is, you know, what it used to be. And so I feel your guys' pain finishing all your rounds before grand rounds, so you can present to your attendings. Today's objectives: understanding some of the vague signs of common childhood disorders early, really in their life, learning how to use some of the tools that we regularly use efficiently to guide your next steps on what to do, and how to approach a complex matter in limited time. So this is a repeat from previously, potential barriers to care. We all know there's 20 bazillion barriers to care. So but there is a way, and we got to figure out that way. And once we get that way down, then we'll be able to really understand. Ruth, can you turn your camera off? Can you turn your camera off? Okay. Moving on. Learning process. I'm sorry, hold on a second. Learning new processes. So want to teach you guys new processes so that you guys know how to manage these things, but I know it's hard. That's a picture of me, a little whiter than I am, trying to round before grand rounds. So differential diagnosis in these kiddos who may have something else going on. And these may be the correct diagnoses, but this isn't everything. So a lot of times we look at anxiety, depression, ADHD, like those are a lot more, or behavioral stuff that families say he's just oppositional, or, and then what we see also is that children will actually think that they are lazy or stupid, honestly, because a lot of parents will say that. And then they'll end up with low self-esteem. So so today I'm really going to go over only the things that are highlighted in blue. And so obviously we talked about before the SDOH and the ACE. And so a quick reminder of what those are. The SDOH, the social determinants of health. And so we do a screener, and I think a lot of hospital settings are doing the screeners to determine whether or not there's like food insecurity and things like that. So obviously if you're not eating well, and even if you're just living in an environment that's stressful because your parents aren't eating well, but you're getting school lunches, there's still a lot of that stress that kids are taking in. So it's something to consider. And then adverse childhood experiences. So having had an traumatic experience yourself as a child, or continuing to have that ongoing experience is going to impact your ability to function. And then, of course, parenting style, which varies greatly everywhere, but I feel like definitely here in Arizona, we have the whole gamut. So those things obviously we take into consideration. But then when you have that parent that comes in and there isn't any of that concern and they're not sure why their child is having problems, then these are some things that I want you to focus on, and I'll kind of guide you on how I do it in the office setting, because obviously you don't have that much time. But dyslexia, autism, ADHD, and mood disorders. So I want you to see this. It's actually, it was the dyslexia paradox when we first made it, but it's basically when you look at, I'm hoping that my camera things, okay, there we go. When you look at, as we go through school, there's some symptoms that kids present with even in preschool. For most of these things, dyslexia, oh darn it, I went backwards. Let me see if I can go back. I can't. I'm just going to end up moving myself forward. Hang on, because I really wanted to go over that one with you. Okay, so dyslexia, autism, other forms of anxiety from early childhood, they will start early. They'll start in preschool, kindergarten, and they will either, get the right support and go through effective intervention and succeed. They'll get a diagnosis. It may not be providing the best support. We see that sadly in a lot of things related to dyslexia in school. So they get a diagnosis of a reading disability or a written expression disability, which is one of the categories that are required for an IEP. And they aren't taught well for dyslexia in school. So in school, they just do more of the repeating rather than altering the method in which they're supposed to teach children with dyslexia. Not because of a lack of desire, but mostly because of a lack of either education or funding. And then those kids continue to struggle. And then there's a whole slew of kids that just get misdiagnosed. Most of the time I see just that they just get labeled as a lazy child, or they get the ADHD diagnosis and then they get incorrect or no support. And so I kind of put those misdiagnosis and no diagnosis in the same category because there are a lot of consequences, including a lot of these kids end up having mental health issues. A large portion of kids in juvie have these types of learning disabilities. And so we owe it to them and to society to really focus on making sure we're helping them. So the sad sign, right, that we're not trained, the schools wait for them to fail, and the parents don't know what to look for. And 10 to 20% of kids have some sort of learning disability or neurodevelopmental disorder. So that's a huge portion of children that have something going on, and most parents and PCPs really aren't trained or don't know about the resources that are out there. And the schools aren't funded. And so even despite the fact that they may want to help some of these kids that they see struggling, they literally have to wait until they fail. So they have to do the evaluations. If they're borderline, most of the time, a regular parent is not going to get those services for their child. So I speak from personal experience in that I'm not a regular parent. And, having gone in for my own daughter's evaluation at school and seeing there was this discrepancy between her reading comprehension at 14th percentile and her some other area, like, average or something, that I was able to bring that to the table and say, obviously there's something going on. We need to delve into this further. She's not learning. She's not doing well in school. How many parents are really going to be able to do that? So that's the reason that a lot of kids fail. And so then they just end up having, maybe they end up with a diagnosis, school or medical, but who's going to get them there? How are we going to get them there? And how do we provide the best care for our patients? So long introduction, sorry, but I just want you guys to understand the importance of this. And of course, I'm passionate about it. So what can we do as PCPs? Learning early signs, referring early, listening to parents. Sometimes it's easier to just be like, oh, they'll outgrow it, or oh, it's not that big of a deal. But if the parent has a concern, it's really important to just be like, you know what? I'm not sure if it's a big deal or not at this point, but if you want to get a referral, this is what I recommend. Or if you think that your child is struggling, I would recommend talking to the school about getting an evaluation. So you can give them a couple of quick things. It doesn't have to take that much time. And you can still let them know if you're truly not concerned, but also knowing that there may be something that we're missing there because we're not trained to see those things. And then of course the SDOH and ACEs, and then also asking the tough questions about the home environment and how they manage things. And you can see it in the office anyways. You can see when the child is misbehaving and how the parent responds. And the parent may respond angry or threatening. But remember that if they're angry or threatening, it may not necessarily be that the parent is a bad parent or they're using poor discipline. It can be because they are overwhelmed themselves. Their child has been driving them insane. I've yelled very loudly at my child to the point where my father told me, this is when she was young, Nilam, the neighbors can hear you. So I stopped yelling at her. And then learning time efficient tools. So again, there's a lot of stuff out there that you can use. I'm really going to go over the things that I highlighted in blue here, but definitely the SDO screeners, the ACE screeners, going with your instinct, your gut instinct. If something seems off, don't avoid it. Just give them resources. And so the IEP is a big one. If you have a school-aged child who's struggling in school or even struggling when they get home, they may be holding it together all day long, and then they get home and they're really stressed out because they've had to hold it together all day long. And then they're misbehaving at home or having tantrums. So asking the parents to get an IEP evaluation, just they have to write something to the school. There's stuff, and I can email that to Megan to send out to you guys, that we learned in the early access to care training about, like, letters that they can write to their school that gives them all the verbal legal mumbo jumbo that they can say, you have 60 days from when I given you written notice and blah, 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 so that the school will do what they want to do. Because again, remember, it has to do with funding as well. The Vanderbilt, I really like, and I feel like it's not utilized completely for being able to see what all the other areas show you. So, or at least maybe I didn't initially. So I'm going to share that with you. And then the PHQ-9 and the GAD, obviously. And so obviously those things are a little bit older. There are some younger kid ones, the pediatric symptom checklist, and for the younger kids. And then there's SCARED, which is a really detailed, and they're available online. They're free. And they're really detailed questionnaires that give you the same sort of idea of if there's depression or anxiety for this child. But then again, we have to go down to, is that depression or anxiety rooted in school failure, something in their home life, undiagnosed social anxiety or autism or something like that. So, and there are other screeners. I'm putting a plug for our dyslexia screener, which we've been working on with Phoenix Children's and ASU. And eventually, once we get more funding, we'll be asking all the PCPs to help us with this dyslexia screener, but that's it. So learning disorders versus neurodevelopmental disorders, which obviously can be combined too. So you can have, when you want an IEP in school, they have to have a diagnosis of a learning disorder. They may come to you and say, oh, the school said that I need a medical diagnosis to get an IEP. Wrong. They don't need a medical diagnosis. Actually, we're not supposed to get involved with the school system, and some of the school systems get upset when we get involved and we even write anything. So I usually tell parents, if their school is really telling them they need a medical diagnosis, ADHD can qualify, autism can qualify. They call them other health impairments. Usually it's a specific learning disorder in reading or writing that sort of starts the ball rolling. And that's if you're going to get that IEP. But then you can also have these other neurodevelopmental disorders that do not impact your learning, but still cause behavioral issues. So if you have dyslexia, but you're able to memorize the shape of the words, your scores will show fine. You won't show any problems until you're like in 4th grade, when you're finally at that point where you are having to read to learn. So the first 3 years of school are learning to read. And then after that, starting in 4th grade, it's reading to learn. So if you're memorizing the shapes of the words and you're getting by with reading, but you're not really comprehending, it's not going to show until you're older. Again, the setup for failure. But there will be early signs of struggles, emotional issues, behavioral issues, all of that in that first preschool, kindergarten, 1st, 2nd, 3rd grade. And so dyslexia is sort of considered a neurodevelopmental disorder. And the rate ranges anywhere between 7 and 17% of the population. That's a large portion of children. So you definitely have children with dyslexia that you've seen before. And then similar with autism, which is obviously not such a large percentage, but still a pretty decent amount of kids. And those kiddos will have that, they'll either have total behavioral issues or they'll be masking all day long. So this is just a partial slide that obviously didn't get certified. But the IEP, full psychoeducational evaluation with specialized education. So they get actually taught differently, taught separately. And like I said earlier, if you have dyslexia, they're not necessarily teaching you the way you're supposed to be taught, but they're attempting to. And then the 504, so if you have a neurodevelopmental disorder that is not impacting your education, you can get a 504. The 504 will provide accommodations, so maybe a quiet place to take tests or longer time to turn in homework. But whether you have an IEP or a 504, that's still masking the underlying problem if it's a neurodevelopmental disorder. If it's a learning education, like a specific learning disability, you're going to get really good resources in the school setting as long as it's not dyslexia or some other, there's obviously a few other things, right? So this is going into now the tools that we use. So the Vanderbilt I love because it is broken down into these sections. And if you just pay attention and realize that the conduct and oppositional is not ADHD, in my experience, for the most part. If there's conduct and oppositional behavioral, there's more than ADHD going on. So, and even if it's ADHD is a rule out diagnosis. We can't rely on just answers from people saying they're behaving a certain way because we don't know why they're behaving that way. And it could actually be that they have something else underlying. And I'm going to, again, go into what my experience. And so the one of the reasons that I'm very passionate about this, I didn't learn to diagnose autism until after my daughter was I learned to diagnose autism before my daughter was diagnosed, but I knew that there was something going on. And eventually she got diagnosed with autism and dyslexia. Prior to that, we tried her on ADHD medications, which none of us want to medicate, right? But you're a parent, you're seeing your child struggle, you know your child can do it, what's going on. And it was horrible. Like, it just dulled her personality even more. Obviously, a girl with autism trying to mask her way through life, getting medications. And it was relying on just the questions, right? None of us were wrong. We just didn't know as well, right? So just kind of keep that in mind, that just because it may look like ADHD, and especially if it's inattentive type, where they're not paying attention. If you can't read or write, how long are you going to pay attention all day in school for 8 hours? Or if you have autism and you're not great with making eye contact, how much attention are you going to really pay? Like, according to what they think. By the way, kids with autism, for the most part, who do not make eye contact, are hearing every single word you're saying. So be careful. So, and then pay attention to the emotional part. But again, there's so much overlap with all of this. So, and then, the performance typo, sorry. And so this is obviously a very busy slide. I'm not going to go into detail on it. But I did want you guys to see the Vanderbilt scoring sheet, which you can find online, and it tells you how to assess it. And remember that there's these, the first 9 are inattentive, the next 9 are the hyperactive, the combination of the both, and then looking at the oppositional and the conducts questions. If there's anything significantly positive in those, look more. And then obviously the anxiety depression screening, again, look more. Don't just, especially if it's in both the teacher and the parent. So, and then the other screeners we were talking about, again, just a little view of it, but the GAD and the PHQ, which is for the older kiddos, and the pediatric symptom checklist and the SCARED, which are much longer. But obviously, if you have a child who you're worried about and the parents are saying all these things are going on, you don't have much time, you can have these forms available, right? And just pull them and say, here's a packet with parent Vanderbilt, teacher Vanderbilt. If it's a child that's young, pediatric symptom checklist and a SCARED. So you give those 4 things to the parents and say, fill these out and let's regroup in 3 weeks. Or if they're older, instead of the pediatric symptom checklist, you can do the PHQ adolescent. That's why that one has A over here. And you can do the GAD, or you can do the SCARED if you're really concerned, trying to figure out why the child may have more anxiety. So the SCARED really breaks it down into like panic, phobia, social anxiety, separation anxiety, all those things. So kind of coming to that objective of how do we do this in such limited time, and how do we handle such a complex thing in very limited time? And so parent comes in very concerned about their child's behaviors. Pay attention to if it's at school only, if it's at home only, if it's at both. It gives you an idea. You can kind of delve into a little bit more, like, is it parenting style? Is it that, there are more things that you can be doing that are similar to what they're doing in the school? Yeah, I've tried that. Nothing explains it, right? So then we say, okay, well, let's look a little bit more. How about we fill out these forms? And then, regroup, and we can look at these areas overall and just see what's going on. Your option, if you don't feel like there's any mood related stuff and it's mostly just behavior, is to also just do the Vanderbilt first. And then when they come back, if it comes back with the anxiety depression being positive, then you can go into the more deeper questionnaires, basically. But then when they come back, what do you do, right? Even if it comes back as everything is complete, inattentive, hyperactive, conduct, oppositional, anxiety, depression, and school performance, you still have to choose which way you're going to go, right? Because it's confusing and you don't have the ability to answer this question in your primary care setting where you have limited time to determine what's really going on. But at least one, it says to the parents, you're hearing them. Two, it says to them that we need to look, and then you got to figure out where you're going to send them or what you're going to do. Some people will treat some things in their office. There are some clinicians still who had trained with the EAC that do the diagnosis themselves for autism. And we do, I know there's lots of changes in the environment for getting the autism diagnosis, which is why we opened up our clinic. Dyslexia, there's nothing that I've found that's going to give them a diagnosis early in life, or I'm sorry, free or covered by insurance, which is why there's a small portion of our clinic where we do that, because I feel like that's a disservice to the community and to the children that we're taking care of. And then mood, obviously, we have lots of options out there. So, but then again, can it be one or two or all three? And so that's when we go, okay, how do we know the difference? I'm going to go over autism and dyslexia a little bit more to kind of give you a little bit of an idea of things that you can just use as tools to determine whether or not you think that could be something that's going on. So usually older kids, if they haven't been diagnosed so far, they're masking their symptoms. So with autism, what happens is it's a social anxiety, it's a social immaturity, it's a social developmental delay. So kids learn how to communicate in our universal language, our body language, before they actually start with like full communication with words. Before they're 16 months, they use 16 gestures. So pointing, waving, nodding, I don't know, uh-oh. And they're usually a combination of a body gesture, eye contact, and a sound, right? Words are just sounds that we've made up in different languages. So it doesn't have to be the word, but usually that's what they're doing. They're trying to convey something. So this happens all before they're basically 15 months. You see those kids by the time they're typically developing their 15 months, they are running the show, and they can figure out everything and anything. Basically, parents can't hide anything. They have to start spelling in front of them at a very young age, right? So there are kids who are able to learn those things, but it doesn't flow naturally. And so they learn it all, they see it, they mimic it, they go through life just kind of mimicking their way until it gets a little bit too complex. And now you can't mimic your way through life. You can't say, oh, when this happens, that's supposed to happen. And when this happens, that's supposed to happen to everything that's happening in your entire day in school. So parents compensate for their kids, and then all of a sudden they're in school, nobody's compensating for them, and they are frustrated. They may either shut down, or they may explode, or they may mimic their way through the day and do everything that they're supposed to do. They're considered the really good kids. They did everything. They're the best kids. They're the teacher's helpers. And then all of a sudden they break down when they get home. And usually social immaturity in certain areas, difficulty making friends, difficulty understanding some of those social rules, not understanding when kids don't want to play with them, not understanding tag. Tag is a body language game, right? So they're not or hide and seek, like not really knowing who's hiding, who's seeking, and basically just can't read the room. So as they get older, they don't understand what's appropriate and what's not appropriate because they're not reading those facial expressions and those social cues that they're getting from people, teachers, as well as other kids. So a couple of things just for me to throw it in there, and also let you know when you're presented with a child that is masking their way through life with autism. The lack of empathy misconception. It's a lack of expressing their feelings the way we express ours. So it's more of they can't see and understand what our facial expressions are. So I'm going to give you a funny example, and you will laugh, and I won't be able to hear you because everybody's on mute. But when we say yes and no here, right? Even if they're not using a language that you're using, right? They're going to be like, yeah, no. How do they learn that? They've seen their parents and they've mimicked what they've done, right? How does the Indian kid living in India know what those things mean, right? Oh, yeah, yeah, yeah. Oh, yeah, I understand. Yeah, yeah. How do they know what that means? Because they've been seeing it and learning it and mimicking it. And we do that naturally. You have those neurotypical kids that are like mimicking you when you're washing your hands. They're doing all that naturally. Kids on the spectrum are delayed in that. It's not the inability to do that, it's that they need to be taught, or they learn it, but it's just work for them to do it. It just doesn't come easily and naturally. So then when you're expressing emotions, those are very subtle things that you don't really pick up on as easily if you are on the spectrum. The tiny little movements in our face that we take for granted. There's these things called micro expressions. It tells the entire story if you look at someone and how you can communicate when you're in a different country, not speaking the language. That's our universal language. But those tiny little things are things that kids on the spectrum haven't been able to pick up on. And it's a spectrum, so there's a whole bunch of different things that they're going to present with. But just going down to the idea that if you have autism, it means you're not smart. Really, the higher intelligence level, the better able they are to mask, and then they will have more meltdowns, more problems in school, more misdiagnosis, and it's also a comorbidity. So you can have ADHD and autism. There's also a higher risk of dyslexia in kids with autism. So there's all these neuro differences. And then the whole, they're not able to play with other kids. They usually do want to engage, they just don't know how to. It is a form of social anxiety. And so if you have a kid who you think has social anxiety, that's still a reason to look at dyslexia, because some, especially girls, they'll present that way. And then a lot of times people just don't want to look at it because of the myths and the labels, and they think that it's going to mean all these different things. So usually when I tell parents that I'm going to refer them for something, if I'm seeing some of these things, I'll tell them social emotional communication is a mile track in development, just like gross motor, sitting, crawling, walking, running, climbing. Social emotional development is how you get from that, having that back and forth cooing conversation as a baby, at really by 2 months at the latest, all the way to getting to the point where you can have a presentation where you're typically presenting to people who are responding to you, but different world, and have that ability to understand when people are listening to you, looking at them, being able to answer questions when they come back to you, all of that. So that's a whole track of development. And that's the track of development that we're working on. And so if kids who have gross motor delays get physical therapy, it helps, right? This is just a different type of delay, and therapy helps. So, or if they're totally not listening to you at all, you can just say, there's some social communication developmental milestones that I see maybe impacting your child, and we may as well just get an evaluation to make sure we're not missing anything. Okay. These are some things, just in addition, that I did want to focus on, really to just help you understand some of the other signs you're going to see. So the delays in using and understanding body language we talked about. This hand tension thing, their sympathetic nervous system is active because they're trying to like function in this world without being able to communicate. So there's this rigidity that they have in their hands. Usually they'll be holding one toy and the other hand will have tension in it. Masturbation is a normal thing that we say for children, but if it seems to be that they have a hard time keeping that in their own setting, or it's excessive, that's a sign of stress. And so there's many other signs of stress that will show you we need to look at something more. I had a kiddo, I mean, she's not school aged, obviously, but I had a kiddo who had like trichotillomania at 9 months. She was literally pulling her hair out of her head and eating it. She had autism. but she was just managing, but it was very stressful for her. And so that level of stress of not being able to communicate is going to create all these different presentations. And then atypical speech. If there's a lot of repetitive, so if you're saying something and they repeat what you say after you've said it, and these things happen all the time. And before I did my training, I didn't see it. And then after I did my training, I was like, oh my gosh, it's like everywhere. Like I have a kid coming in with a cold who's got severe delays. And I'm like, oh, how do I bring this up? Anyways, so there's a lot of things that you'll see if you pay attention. So the pronoun reversal is more, when we see it more with autism, it's going to be more of, do you have to go to the bathroom? Like that's what the child says. Do you have to go potty? And so they're asking the question back to the parent because they're repeating what they've seen the parent ask them when they have to go potty. They're not really understanding how to use the words to communicate. Or very formal, like when you see a kid and you're like, wow, that kid is like really precocious and they're just 3 years old and they're talking like an adult and they're having a conversation with an adult. Huge words that parents are like, I don't even know how they've learned that. Those kids can be mimicking their way through life too. So, but it's not going to be just that. They're going to have other repetitive behaviors too. So it's the social communication delay, as well as some of these other repetitive behaviors like that hand tension or, masturbation can be that, or even the repeating the sounds, but then also sensory things like getting really upset with the ear exam, or hyper focus on a character. Like they have to have, I had one girl who was obsessed with Moana and she would not wear anything except for this one Moana dress, and she would carry Moana with her. And every single appointment, every time I would see her, and she would only watch Moana, and it was just extreme. So those are the things that, if parents are saying something, then kind of look at it. And then of course, why are we scared to talk about it? Right. I mean, nobody wants to talk about it with their patients. Nobody wants to say, oh, I think your child has autism. It's not like, oh, I think your child has an ear infection. Let's treat it. And there's a lot of, parent fear. Then the clinician is fearful of saying anything. Perception of what it means to be on the spectrum, especially because, people just believe that it's that child that's flapping in the corner and not talking. And of course, those kids are the obvious ones. But the diagnosis rate has increased so much because we're able to see there's so much more autism out there. It's just presenting differently. And then the time it takes, right? Why we're scared of it. We don't feel like getting into that whole conversation with them. And then the idea that kids on the spectrum have a cognitive delay. So how to kind of put a positive spin on that. So I'm going to go to the next slide. I'll explain that one to you. But this one goes over, and I think I may have used this slide before with you guys when I talked to you, but the rate of diagnosis of intellectual disability. This isn't even that old, but I mean, if you go back, like they had done studies for so many decades before too, and it's the same. And the rate of autism diagnosis, and the autism diagnosis is increasing, yes, but the intellectual disability diagnosis is decreasing. And a lot of these kids may be misdiagnosed as intellectual disability because autism is a communication delay. And if you're not communicating with somebody, how are you going to be able to tell what their intellectual capacity is? You guys have probably heard that whole thing, like we only use 10% of our brain. Well, what 10% are we using and what 10% are they using? It doesn't have to do with the lack of brain function. It's different parts of our brain that we're using. And they've done studies and PET scans to see where kids are using, what part of their brain they're using. So I like to point that out. And that's a positive spin that you can tell parents. And the later they get diagnosed, the more likely they are to be at a higher intellectual capacity, just not understood because we're not able to really see what's going on. We're not able to grasp that because we're using different forms of communication. So And this was another study, and I thought that was interesting how it's now crossing over. So I don't know how large the population of this was, but just interesting that it's happening. I'm not going to go over this grand slide, but you guys will get copies of it. But just remember also prematurity is an increased risk factor. So definitely extreme prematurity or really long NICU stays, low birth weight. But they have the number of weeks that you're in the NICU increases the risk of having autism. And also they have more of the DSM-A, which is the social communication stuff, and less of the DSM-B. So the DSM-B is that sensory stuff, the repetitive behaviors, the restrictive, like I need this to be this way, food aversion, or like hyper focusing on certain topics like license plates or numbers or things like that. So the premature babies are more likely to have more of that DSM-A, and then they're also more likely to outgrow it with therapy, obviously not without therapy, but, and I'm not gonna go over that screening tool thing because I wanna make sure we have enough time to talk about dyslexia. And then the current rate is 1 in 3. And the prevalence keeps increasing as we're more aware of it. Is it that there's things that are changing in society? Parents will ask, why do we have more autism diagnosis? Well, there's definitely more awareness. I won't go into the hot topic of the day. But there's just earlier recognition, more diagnosis. There's a bunch of people, adults that have been out there that are a little off, a little quirky, but are able to get by. But there's a lot of social anxiety and a lot of stressors too, and a lot of depression and mood issues that have come from kids not getting diagnosed early. And then they're your behavioral kids when they're older, adolescent years. So just kind of keeping in mind that it's gonna be a very large variety of patients that are gonna be walking in, and it's a pretty high rate that you would see. So, okay, so moving on to dyslexia. And I don't know how much time I have. I can't see it on the screen. Okay, cool. So dyslexia. Large population of people who have dyslexia in this world. It can look like ADHD, it can look like anxiety, it can look like laziness. One of the good questions to ask is, does your child do better if you read the questions to them and they answer it verbally versus you having them read it and write it, or even just when they're doing sight words? If they don't want to do it and they're struggling and they're complaining, if you're asking them to write it, but then they do it verbally fine, that's a very big telltale sign that there's some difficulty there. That is more likely to be dyslexia. And then the flipping of the letters, a lot of teachers will say it's okay, sometimes past where it is okay, but a year and a half of school. So technically a year and a half of school of learning the letters. So even if they've had preschool and they work on the letters, that's enough. But otherwise, usually we say like middle of first grade, they shouldn't be flipping letters anymore. So they shouldn't have to use the different skills like bed, so that they can figure out which way the B goes and the D goes. And then that's also going to end up with flipping numbers, 9s and 6s, 2s and 5s. So it can cause difficulties with math stuff. And they do have a difficulty with following steps. And that kind of goes into that whole neurodivergence area where there must be some other component to it or another part of their brain that they're using. We know they're using a different part of their brain, more so the more three-dimensional world rather than the two-dimensional scientific world. And then the other thing, I tell parents when their kids are young, like 3, 4, and they're still doing this little baby talk, or they say like things like aminals versus animals, and it's cute. Oh my gosh, I'm not going to tell you my funny story, but I have a funny story for those of you who want to ask me later. But K's sounding like T's, So tat instead of cat. Um, those are the things that are early signs that there's processing issues with those sounds. We know they should have 100% clarity of speech by the time they're 4. There may be some letters that are off, but really things like that that are so obviously off, they should have mastered by now. And if they have not mastered that, and speech therapists will tell you like they should have mastered everything by now. They shouldn't have any articulation issues when they're in school. But if they haven't, then they've not processed that information properly. So they're not putting it into the right place in their brain. So then when you say, okay, a B makes a B sound and you put it in your brain, as long as you have it in a very easy place to retrieve, and then you say, okay, now I've got to make this B sound into an image that is two-dimensional. And there's nothing that's two-dimensional in this world. And so then we have to convert that into from our three-dimensional image onto a piece of paper. And even a piece of paper isn't two-dimensional, right? My daughter will argue that neither is a letter because there's graphite, but the letter has got to be flat. And so if you imagine things in your brain as everything else in the world is, a D can be a P, can be a B, can be a number 9, it can be a lowercase q. There's so many things, and that's just one image, right? And you've got to struggle with all of that. And so then sometimes what kids will do is they'll actually put capital letters in the middle of words. These are things you're not going to see. You're not going to do a handwriting sample to kind of figure out what's going on. But just knowing year and a half of school, they're still struggling with flipping their letters. They don't have problems like ADHD type problems with getting ready for school, which some kids will still, right? There's the crossover, you can have ADHD as well. And there is some difficulty with following steps. So, but if it's clear this kid is, the parents are like, oh yeah, he gets ready for school on his own, his backpack is on, he's, out having breakfast, but in school he's struggling with focus, then that's not ADHD, right? Because it has to be present in multiple environments. Then that's a school learning disability. And just going through a couple of other tiny little things, and I'm not going to delve into it too much because I do want to figure out if there's time for questions. But just the confusing of the symbols, the idea again that people think it's low IQ and that's why they can't do it has nothing to do with low IQ. And same thing, you're not actually getting presentation of what they're actually able to think because they're having to write it down and they can't write it down. And then if you're asking them to read word problems for math, you're not getting any information on what they're really understanding with math. ADHD presentation, usually inattentive if it's just dyslexia, but not always. Some kids are going to have outbursts because they're frustrated. And then the earlier the diagnosis, the better, so that you can get to the point where you're using those first 3 years of school to learn to read, right? So if we can get them diagnosed early, there's programs out there that are available. They don't even need a diagnosis. They just need accommodations. They can go to the International Dyslexia Association and look at all the resources that are there and be able to get help that they need. A diagnosis really only helps you with the school if you're having to get accommodations in school and the school isn't helping you. So, and this is what I was talking about with some of the sounds, switching letters, but also dropping letters, sounding like they have an accent. And then guessing words. Fire, days ago, there was a 5. Just a flipping, right? If you're guessing the words when you're starting to read, it doesn't make any sense. So when you get to that reading to learn, you're memorizing the shape of the words and you can't actually get the concept. And that's when it shows, but the problems have always been there before, and just seeing the level of the frustration. So that's really most of it. There is a family history. That's the other thing I wanted to tell you. And then again, I told you about all these things failing in 3rd or 4th grade, articulation delays, flipping letters. So I'm going to I'm not going to talk about these things because we only have 10 minutes unless you guys want me to, because I want to see if you guys have other questions on stuff.
Thank you. I don't see any questions in the chat right now. One of the points you discussed was talking with parents about accepting the diagnosis of autism. I know historically there's been a hesitation for ABA and concern about how that is with children. How do you address that concern with parents?
So ABA has a bad rap for a real reason. So ABA, like everything in life, it starts out, they're trying different things. They were trying this method called DTT, which is discrete trial training, to basically train the child on what to do to respond. And they still use this method for kids who are severely delayed and giving a reward base and all that other stuff. But there's also the ABA that teaches those social and developmental milestones. And so what I tell parents is that, yes, there's a reason to be worried, but you need to find the right resources. And if you have the right guidance and you find the right resources, then your child can flourish with ABA. So it's knowing how to find that ABA. There's a bunch of stuff, and I don't know if on my PDC website we have something on that. But basically, if you're focusing on the social emotional developmental milestones and you're telling them you're working on therapy for the social emotional developmental milestones, that therapy, the ABA, should be for that. So ABA is just a generic word, a number of words that says applied behavioral analysis. So it just means we're going to try something, see if it works. If it doesn't, we'll try something else. The methods that they use underneath that are what matter. And so the two big kind of categories is DTT and NET. And DTT is discrete trial training, which I tell parents is the making your child into an anxious robot. And then there's the NET, which is the natural environmental teaching. And that's basically what you would do as a parent when you're trying to teach your child to understand and use these social cues. An example that I give parents when I'm diagnosing them to know is that, and it varies for everybody, right? So you need to rely on the person who's actually in charge of the clinic and providing you the therapy for your child. And you need to realize that this person is going to be working you side by side and helping you raise your child. And so if you do not feel comfortable, if there's any possible doubt about what they're saying, then you just don't go there and you look for something else. But one of the examples of the type of therapy that we did for my daughter was we played charades. So she was older when she got diagnosed. So we did charades first she learned like what facial expressions meant in pictures, and then she learned in movies. And then we would all play charades for emotions, and we would act things out. She would guess, we would guess. And it's just learning how to read people. And now she reads people too much and she worries too much, but not in a bad way, not like that anxious robot way, So it's just knowing that there are a variety of options out there, and you just need to know what to look for.
Thank you.
Are there any other questions?
Hey, Nilam, it's Gina Montian. Hello, good morning. Hey, so with the ABA, what about with ABA and nonverbal kids? I find that they seem to flourish more when nonverbal kids are doing ABA, but that may be just me.
Well, I love ABA for all of them. The nonverbal kids, they end up doing more DTT in some places. But for a short portion, and then moving into and a very small part of it, like it's not all of what they're doing. And so, and it all goes with the BCBA, but like, I love ABA. There are bad types of ABA. I've seen those kids that are like so anxious, they don't even know how to answer the question, how are you doing today? And they have to look at their mom and I'm fine. And that's those kids that were, highly verbal and went through DTT, before there was much availability, or maybe the parents weren't aware or whatever. So, but yeah, definitely with the nonverbal kids. And they also have the communication devices they use to help them communicate as well. And that And that really helps a lot too. Did I answer your question? Gina.
Sorry, I was here. I was just not within arm's reach. Kinda, yeah. It's such a
Yeah,
mixed
tell me
bag.
what your question is really.
Well, I find that at least my nonverbal children who get ABA, and I'm assuming it's the NNT type of ABA,
Mhm.
seem to thrive more with their speech. I don't know if it's just maybe extra practice. Maybe that's what it is.
Well, no, they thrive more. So the ABA that we I recommend is the NET, which is the natural environmental teaching. And they do thrive with speech because basically, if you think about social developmental milestones, right? You have the cooing back and forth, you know, when you're like 2 months or whatever. And then you have the 6-month-old, which is my favorite age, where they're like laughing to get your attention and trying to get you to engage with them. And then you have the 9-month-old who's playing the games and like throwing things on the ground and waiting for you to pick it up and looking at you. And you have all these developmental milestones that are not verbal communication skills that they're mastering before they start talking. And so the type of therapy that works well is the type that's actually building those milestones, teaching those milestones, and then words will come. When words come before those milestones have come, it's usually disjointed. It's usually not very good with communication. And so a lot of times you'll have these kids who are counting or saying their ABCs, and the parents are like, oh, they're so smart, but they're not really communicating. They're just using words as labels. And so the NET type really helps fill in that social emotional communication foundation so that they can understand the people around them and what those people are trying to communicate to them. And then they start using words and using words appropriately. Hopefully that second try worked. Let me know.
Thank you. Yes.
Okay. Other questions? You know, we're coming close to the end of time, so. Even though I talked.
Okay. I don't see any more in the chat. If anyone else has anything to unmute and ask, otherwise, thank you. This has been a great, very helpful discussion, and really appreciate your sharing with us this morning.
Thanks for being here and listening.